A pleasant day to everyone. I am Cyril Jonas M. Planilla, your lecturer for today's session on cancer therapeutics and the pharmacology of cytotoxic drugs. In this session, we will be talking about the general principles of cancer therapeutics. Specifically, we will dive into the cytotoxic chemotherapeutic agents, their key mechanisms, pharmacokinetics, and adverse effects. For any questions you may have about cancer treatment and the chemodrugs we will be talking about today, feel free to send me an email. This is the outline of this lecture. First, we will be talking about the basics of cancer therapy and incorporate the basics of the cell cycle. We will relate it to the cell cycle specificity of cytotoxic agents and then discuss the major mechanisms by which cytotoxic drugs are able to exert its anti-neoplastic effects. As a disclaimer, our topic will only focus on the common cytotoxic drugs used in practice, and we will only cover conventional chemotherapeutic drugs. Hormonal agents, biological agents, and targeted immunotherapies are meant to be discussed in another avenue and are meant only for those who are brave enough to venture into further studies in oncology. So let's begin. Cancer is the leading cause of mortality in developed countries and the second leading cause of death in developing countries. It is caused by uncontrolled and malfunctioned cellular replication. Not only is there a failure of the cancer cell to maintain its specialized function, but the cancer cell competes to survive using natural mutability and natural selection to seek advantage over normal cells in a recapitulation of evolution. One important thing to note when you are dealing with cancer is that a tissue biopsy should be obtained for you to diagnose that it is cancer. This is the main dictum of oncology. Never diagnose and treat cancer without obtaining a tissue biopsy. The diagnosis of cancer relies most heavily on invasive tissue biopsy and should never be made without obtaining tissue. These are the goals of cancer treatment. The primary goal is cancer cure, wherein the main goal of the treatment is to eradicate the cancer. If this primary goal cannot be accomplished, the goal of cancer treatment then shifts to cancer control, wherein the primary goal of cancer treatment shifts to palliation. Mainly, the main focus of the treatment is for symptom control, the preservation of quality of life, while striving to extend the lifespan of the patient. A main goal of cancer treatment is also to not do harm, basing on the dictum primum non nocere. When cure of cancer is possible, cancer treatments may be considered despite the certainty of severe and perhaps life-threatening toxicities. However, every cancer treatment has the potential to cause harm, and treatment may be given that produces toxicity with no benefit. The therapeutic index of many interventions may be quite narrow, with treatments given to the point of toxicity. Conversely, when the clinical goal is palliation, careful attention to minimizing the toxicity of treatments becomes a significant goal. Therefore, when discussing cancer treatment to a patient, the risks as well as the benefits of cancer treatment should be weighed and discussed with the patient. There are two major types of cancer treatments. Those under local treatments include surgery, radiation therapy, and ablative approaches like radiofrequency ablation and cryosurgery. Systemic treatments, on the other hand, include cytotoxic chemotherapy, hormonal therapy, molecular targeted therapy, and immunotherapy. Let's review the main types of systemic treatments. First are your cytotoxic agents or your conventional chemotherapy drugs. These drugs target DNA structure or segregation of DNA as chromosomes in mitosis. Another type is your hormonal therapy that capitalizes on the biochemical pathways underlying estrogen and androgen function. These hormonal therapies find clinical utility in cancers that are very responsive to hormones, such as breast and prostate cancer. Targeted agents, on the other hand, are small molecules designed to interact with a defined molecular target. Examples of molecular targets are your oncogene products, cell cycle inhibitors, and cell death regulators. Biologic therapies, on the other hand, are macromolecules that have a particular target, such as your anti-growth factor receptor or your cytokine antibodies, or may have the capacity to induce a host immune response to kill tumor cells. In cancer chemotherapy, the usefulness of any drug is governed by the extent to which a given dose causes a therapeutic effect. The therapeutic index is the degree of separation between toxic and therapeutic doses. In the case of anti-cancer agents and toxicity to tumor cells, the currently used chemotherapeutic agents have the unfortunate property that their targets are present in both normal and tumor tissues. Therefore, most chemotherapeutic agents have very narrow therapeutic indices. Cancer chemotherapy may be used for the treatment of active, clinically apparent cancer. The goal of such treatment in some cases is cure of the cancer, wherein there is elimination of all clinical and pathologic evidence of cancer and return of the patient to an expected survival no different than the general population. In terms of the timing of cancer therapy, cancer chemotherapy is termed adjuvant if it is given after surgery or radiation, even after clinically apparent disease has been removed. The adjuvant chemotherapy often targets micrometastases that are residual cancer cells found in the tissues after removal of the main tumor. Neoadjuvant chemotherapy, on the other hand, is the administration of chemotherapy before any surgery or radiation to a local tumor in an effort to enhance the effect of the local treatment. An example of neoadjuvant chemotherapy is in breast cancer, wherein chemotherapy is first administered to stage 3 breast cancers in order for the tumor to shrink in size before surgery is done. For us to get to know the main mechanisms of the therapeutic agents used in chemotherapy, we need to be familiar with the cell cycle. The cell cycle is composed of four main phases: your G1 phase, your S phase, your G2 phase, and your M phase. Most quiescent cells enter a quiescent phase termed your G0 phase. Most dividing cells usually undergo the cell cycle, and this cell cycle process is very active in malignant cells. Your G1 phase is the phase that precedes DNA synthesis. Your S phase is the phase wherein DNA is replicated, and your G2 phase is the interval following the termination of DNA synthesis. Your M phase, or your mitotic phase, is the phase in which the cells enter mitosis and divides into two daughter cells. Now, if you notice in the cell cycle, certain chemotherapeutic drugs have been shown to exert their major effects on the different phases of the cell cycle. Hence, drugs can be cell cycle specific or cell cycle non-specific. Examples of cell cycle specific drugs include your cytosine arabinoside and your hydroxyurea, which exert their main effects during the S phase of the cell cycle. Also, your antimetabolites like 6-mercaptopurine and your antifolate like your methotrexate also exert S-phase specific effects. Your vincristine, vinblastine, and your paclitaxel, which are mainly microtubule aggregators or disaggregators, usually act on the mitotic phase of the cell cycle. While your other drugs, such as your alkylating agents, your nitrosoureas, anti-tumor antibiotics, procarbazine, your platinum agents like cisplatin, and your dacarbazine, are termed cell cycle non-specific, as they tend to affect the tumor cell regardless of wherever the tumor cell is in the cell cycle. Hence, it is important to relate the mechanism of action of each of the cytotoxic chemotherapy agents to whatever cell cycle phase they exert their efforts on. Most board exam questions will focus on multiple choice questions that ask you which of the drugs act on a specific part of the cell cycle. So I would suggest that you memorize or um, familiarize the cell cycle and the drugs that act on each phase of the cell cycle. Considering that there are a lot of chemotherapy agents in the market, we need to be able to be familiar with the different mechanisms of action of each of the drug groups that we will be discussing. So this is a summary of the mechanisms and the sites of action of some of the most useful chemotherapeutic drugs used in cancer. Mainly, your antimetabolites, your mercaptopurine and thioguanine, which inhibit purine ring biosynthesis, thereby inhibiting DNA synthesis. Your methotrexate is an antifolate that inhibits your dihydrofolate reductase enzyme and blocks purine synthesis. Your camptothecins, etoposide, taniposide, daunorubicin, and doxorubicin block topoisomerase function. Your protein tyrosine kinase inhibitor antibodies block activities of signaling pathways. Your hydroxyurea inhibits ribonucleotide reductase. Your 5-fluorouracil inhibits thymidylate synthesis. Your gemcitabine, cytarabine, fludarabine inhibit DNA synthesis, while your platinum analogs and alkylating agents form adducts with the DNA. Your L-asparaginase deaminates asparagine and inhibits protein synthesis. Your taxanes, your vinca alkaloids, inhibit the function of microtubules, while your arsenic trioxide and histone deacylase inhibitors induces differentiation. So that is the end of the phase 1 of the lecture. Up next, we will be talking about the specific anti-neoplastic agents, their mechanisms of action, pharmacokinetics, as well as adverse effects.